So a very good morning and my sincere gratitude to Dr. Madhu for having me in this IC. So I'll be talking about diagnosing keratoconus, and I'll start with a little bit of tomography because we intend to speak to the general ophthalmologist, but we'll focus primarily on biomechanics, and that's how the presentation would go. So just a brief on corneal tomography. This is the map that we are all extremely familiar with called the 4-map refractive. There are just a certain things that we need to look carefully before we go for any examination. So I'll go over them very quickly. The important thing, one of the important things is look for the quality specification. If there are any errors there, do not try and repeat the scans. Look for the color scale and make sure that's matching in your examinations. These curvature maps, elevation maps, we are all very well aware of. They point out early ectasia and those individuals who are suspicious for ectasia as well. Again, the corneal thickness map here, this is where the numerical values are. So we are all good at picking up these cases of keratoconus. Like in this case, you can see steepening, elevation, thinning. This is a case of pellucid marginal degeneration, as you would know, the crab claw pattern, inferior elevation, thinning. So just an overview of the basics to begin with. And this is the bad D map, which shows the exclusion map, which excludes the central 4 mm of the best fit sphere, and therefore is able to pick up subtle ectasia, which you might have otherwise missed. So these are the corneal thickness spatial profile, percentage thickness increase, the standard deviations, and the D values. So these are all indicators in tomography that help us pick out those early cases of ectasia, which we might have missed. So I'm not going into too much detail in this. This is the topometric KC staging map, which gives you the Bellin ABCD keratoconus staging, gives you the asphericity of cornea in various meridians, and you get various indices. All of these, again, help you pick up fine ectasia or early ectasia. So moving on to the major agenda, which is corneal biomechanics. Why do we really need to know corneal biomechanics? The reason is that the cornea, as this paper has pointed out, is not a piece of plastic. Cornea has viscoelastic properties, which means a combination of viscosity and elasticity. And it is these properties that manifest before any morphological changes of ectasia that you would see on tomography. So if we are able to pick these early, we can actually prevent the development of morphological ectasia. So how do we measure corneal biomechanics? There are 2 different devices that are commercially available. The first one is the ocular response analyzer. So this was the first one to be introduced, which was launched in 2004. It uses a bidirectional applanation process using an air puff and gives you 2 parameters, which is the corneal hysteresis and corneal resistance factor, both measures of viscoelasticity of the cornea. And it's quite evident, as in this image, that these parameters are reduced in weaker corneas. For example, the ones who have keratoconus. The limitations of this machine is that it's not really that sensitive. It's not able to pick up fine variations by itself. So just by itself, it's not enough to have this modality. You need other modalities to complement this. And also the exact correlations of this with true measures of corneal mechanical properties is still not completely known. The newer device, which we now have, which is more commonly used and is gaining a lot of functionality with time, is the Corvus ST, which does air puff induced applanation and uses a Scheimpflug camera to take multiple images to look at the corneal deformation that happens. Unfortunately, that video is not working, but if you have the air puff applanation happening, you would see the deformation of the cornea. So this gives you various dynamic corneal response parameters, like the deformation amplitude, which you expect would be higher in a weaker cornea, deformation amplitude ratio, the radius of curvature. All these parameters by itself also give you a lot of knowledge about the biomechanical strength of the cornea. So for example, in keratoconus, you would see factors like an earlier first applanation because it's a weaker cornea. You would see greater deformation amplitude, like I just mentioned. You would also see a delayed corneal recovery. This is the recovery phase after the applanation. So these are all things that you would see. So just by these parameters also, you can come into decision making. So for example, this is a cornea which is thin and has extremely low deformation amplitude. So when you might otherwise consider this for PRK because it's not a very weak, it's not a very thin cornea, there's no elevation. But considering the biomechanics, you would not want to do any surgery on this particular patient. Whereas, say, this patient has a borderline pachymetry of 500 microns, but extremely good biomechanics. The deformation amplitude is quite low. So such a patient you can even, take up for LASIK, not just PRK. So, but like I mentioned, these parameters by itself are difficult to look at and difficult to really analyze. So what you really need is some normative data which can compare them to the population figures and what is normal in the population. So the Vinci-Guerra screening report was able to do that. And what it also gave you is the Corvus biomechanical index. So again, this was developed using linear regression analysis and uses various dynamic corneal response parameters that I told you about, the one stiffness parameter and also the horizontal thickness. So here you have one index which you can look at and with a reasonable amount of certainty say that this cornea is biomechanically strong or weak. So this has been found to have very high sensitivity and specificity in early keratoconus cases as well. The next need was felt to be able to integrate tomography and biomechanics. Like in the example that I showed you, we had to look at tomography and biomechanics separately and then take a call ourselves. What if we had one index which could look at both and tell us how strong or weak the cornea is biomechanically? So that's where the tomographic biomechanical index helps. This has been found to have in multiple validation studies the highest sensitivity. So this basically, as you can see, is combining data from the Corvus and the Pentacam, and has been found to have the highest sensitivity in detecting subclinical or formifrusty keratoconus. So this is a typical map of the tomographic biomechanical index where you see the Pentacam pretty much looks okay. The BAD-D is fine, but when you look at the biomechanics and take that into account, the tomographic biomechanical index, which you see right at the bottom, is quite high. So this case, even though the tomography is normal, you should classify this case as a subclinical keratoconus and really not intervene surgically if this patient wants refractive surgery. Then there are some newer indices of corneal biomechanics that are available now and that have been more recently introduced because, like I said, the Corvus is gaining functionality quite a lot because of the popularity that it has gained. One of the things that it tells you is the stress strain curve and the stress strain index. So this by itself for one particular individual, this by itself for comparing multiple individuals is not very useful. But when you look at one cornea serially over time, then this does provide a lot of value. So, if you have the stress strain curve moving to the right, that means the cornea is becoming biomechanically weaker with time. And if it is moving to the left, that means the cornea is becoming stiffer or biomechanically stronger. So there is also a stress strain index that has been described to help you look at these values. The value of 1 has been taken as the average elasticity of a healthy corneal tissue based on the normative data and the regression analysis that they have done. And this is also based on finite modeling that has been done by these authors. So again, value of 1 indicating average elasticity, value more than 1 is stiffer behavior, less than 1 is softer behavior. And this is also one of the first clinical parameters that can actually identify stiffening after corneal cross-linkings. The other parameters by themselves were not sensitive enough to pick up those fine changes, but the stress strain index is able to do that. The final index that I'll be talking about is called the CBI LVC, which is intended for patients who've undergone laser vision correction. So otherwise, all the other parameters appear abnormal in these corneas. But here, it automatically picks up that this particular patient has undergone a laser vision correction, and you're able to differentiate between stabilized post-refractive surgery versus eyes that develop ectasia or that could develop ectasia after LVC. So this is particularly useful for these patients. So just to summarize, advances in Scheimpflug imaging technology, whether it is in tomography or in biomechanics, help us detect keratoconus at a very early stage, at the subclinical stage or the formifrusty stage, which was absolutely not possible earlier. And biomechanics, though I do believe is still in its infancy, has really added a new dimension for us to look at when we take our decision on whether this particular patient has ectasia or not, or whether you should take up a patient for refractive surgery or not. And the future, I do believe, lies in combining tomography with biomechanics. And it is meant to not just help us diagnose keratoconus or diagnose ectasia, but to be able to detect weak corneas in their infancy before they even develop ectasia, so that we can treat them or at least prevent the development of ectasia by not intervening with a refractive surgery. So thank you. Thanks a lot.